Okay, welcome everyone. Glad to have you here. Let's see. Oh yes, we're getting pictures. Excellent. Okay. Wonderful to have you here. I'm going to kick us off and get started because we have an amazing program for you today. And I am not going to take up a lot of time to give you a whole lot of background, but PMD Alliance is happy to host these, Parkinson and Movement Disorder Alliance. I'm Sarah Jones with Parkinson and Movement Disorder Alliance. And you are in for a treat, but you're going to be able to hear from one of our treasured movement disorder physician specialist partners who's going to share with you about assessment and screening tools in this current age, as well as in general with clinics, but talking about it as you look at telemedicine. So you're going to be really fortunate to hear from Dr. Yasutoru Yagi, who's going to talk with you. He's with Georgetown, and he is a professor, an associate professor at Georgetown, and also runs the dementia, cognitive and dementia center clinic there. And he is just a wealth of information. You are in for a treat. I am going to turn it over to you. But I do want to say, though, is throughout all of this, please feel free to put any questions that you have down in, if you chat is in the middle, if you're unfamiliar with Zoom, chat is in the middle and the bottom. Put any questions that you have. I will keep track of them and I'll make sure to ask them to Dr. Torres Yagi at the end so that he doesn't need to track it while you're writing them and you don't have to remember them. So this is not a cognitive test. You will not have to remember, put them in as you think of them, and we will ask them. And many, many thanks to Acadia for kind of getting this sparked and getting this going and supporting these educational programs too. So Dr. Torres Yagi, I'm turning it over to you.
Oh, thank you, Sarah. Thank you, Judy. And thank you everyone else for setting this up. I think this is a really wonderful topic. Understanding what it means to one of our mottos at Georgetown is cura personalis, right? And so what that means is looking at a patient and taking care of the whole person, right? And so in order to really evaluate the whole person in Parkinson's disease, you're not only keeping your blinders on and thinking about the motor things that can happen, right? The tremors, rigidity, all the other things that we might see. A lot of the times, what we have to make sure we don't neglect is the understanding of the non-motor symptoms, the cognitive symptoms, the neurobehavioral symptoms. These are the other features of Parkinson's disease that as the condition progresses, we're going to talk about. I think this is a really very, very, very full of content type of presentation. And so I'm excited to go through it with everybody. So although the title is Simplifying Effective PD Assessment and Screening Tools, really, we're going to understand what it is and what we do from a clinical standpoint. Now, it's been 204 years since Parkinson's disease was first described. And this was the Essay of Shaking Palsy by James Parkinson. And before we were able to kind of really understand Parkinson's disease as a whole, we characterized it purely as a motor disorder, and that's kind of what the Essay of Shaking Palsy was. But we learn over time that as the alpha-synuclein and Lewy body pathology comes up from the brain stem, which is down here at the lower part of the brain, and it moves up towards the cortex, that's where we might start seeing more and more cognitive dysfunction. And that trajectory of alpha-synuclein throughout the nervous system usually corresponds with the non-motor symptoms, the cognitive symptoms, this psychiatric, psychosis, delusions, things that can happen in Parkinson's disease. And so here you see the brain bank criteria that I've mentioned before has a lot to do with the motor symptoms, right? We have a 4 to 6 hertz tremor, which means you're seeing a slow, moderate amplitude tremor in certain cases, or you're seeing stiffness or difficulty with walking in the setting of slowness of movement. And you might want to see that a lot of these patients are responsive to levodopa, right? So a lot of the times when we are approaching a patient's diagnosis. Not only are we doing a full neurologic exam, but we're also using ancillary tools like mini mental state exam or a Montreal cognitive assessment. We might get brain imaging, laboratory work like a thyroid function or B12, folic acid. We might check for other causes of infection. We'll do depression screening, neuropsychiatric testing, genetic testing. So this is kind of, whenever we first meet a patient, if you want to be thorough and really find out exactly what's going on, these are the different types of tools and assessments that we look for. We do what's called brain neuroimaging. That's an imaging biomarker. We might do a DAT scan, which is a dopamine active transporter scan. If we're looking for Parkinson's, we might see, rather than two comma-shaped structures, we might have two period-shaped structures that might correspond with the deficiency in dopamine. What about the different things that we look for in the clinic? Right now, we can do them virtually with telemedicine. Of course, that's a modified version. But what about the finger tapping, the opening and closing? We do what's called the Unified Parkinson's Disease Rating Scale to understand the severity of the motor symptoms that our patients might be suffering from. And then we can stage the condition, right? Based on symptoms. If we have unilateral symptoms, you're a stage 1. Stage 2 means bilateral symptoms. Stage 3 means you have difficulty with gait. And really what we're doing there, we can actually see a change in the Hoehn-Yahr stage or an improvement of motor symptoms with medicine, right? One might be when they're in an off state, might be a stage 3, but when they're in an on state, they're barely a stage 1, right? And so the medicine can make a difference, especially in changing what stage we're in. Now, you might notice that when you go to the movement disorders doctor, they might ask you to scribble some stuff down, right? They might ask you to write your name, write a sentence, draw a spiral. So that's something, believe it or not, a spiral can tell you a lot about what condition we're dealing with, right? Because whenever we're trying to come up with the accurate diagnosis, we're trying to understand, why is the tremor there? Is there a superimposed essential tremor? Is it a Parkinson's disease-like tremor? Is it a dystonic tremor? Dystonia means tightness in the muscles, right? And so you might see, if you have micrographia or decreased handwriting, small handwriting, or a small spiral with mild undulations, that's more consistent with a Parkinson. Essential tremor, you might have a bigger spiral with moderate oscillations. And then a dystonic tremor has a directional preponderance. And so it's a very much a clinically oriented field. The neurologic examination becomes more and more important for all of our conditions within neurology, but very important in Parkinson's. We've talked a lot about non-motor symptoms, right? The different organ systems that can be affected in Parkinson's disease. The GI tract, we know that a lot of things can happen from the esophagus to the stomach to the small intestine. We know that we might get deposition of alpha-synuclein in the parotid and submandibular glands. We know that drooling can be a symptom of Parkinson's disease, right? That's also part of the oral GI tract. So our UPDRS motor score is only one part. So when we do our finger tapping, our opening and closing of the hands, we put our hands right front and we flip them over. We check for rigidity. We put your hands on your shoulders, ask you to stand up and walk around. That's only one part of our total UPDRS rating scale, right? Look at all of the aspects that we are always trying to understand. We try in our clinic for our patients to have a full UPDRS motor scale testing examination at least once a year, right? Because we want to understand the activities of daily living. What aspects of the cognition are affected? Are our patients depressed or anxious? Are they feeling less motivated to do things? What about doing things like eating, dressing, turning in bed, walking, all of those things that are motor function testing questions? And what about part 4? What about dyskinesias, fluctuation, wearing off? So all of these things can be rated with our UPDRS rating scale. We also might do what's called on and off testing. On and off testing means, can we see if you respond to actual carbidopa levodopa? If the answer is yes, then that helps us determine whether or not sometimes we're dealing with a Parkinson's disease or what kind of dopamine deficiency we might be dealing with. Of course, understanding the causes, it's not one thing, right? We always think about environmental causes, aside from other causes. Just getting older increases our risk of developing Parkinson's disease. And then genetic risk factors, right? So we know that increasing age, we know males are more affected than females. We know that if in patients that have a traumatic brain injury, we might have to screen them for Parkinson's disease at more regular intervals. Exposures to things like well water or pesticides. We might hear in our patient population that there might have been exposures like that. Genetics, right? When we think about all the different assessments that we do now in 2021, there are things that we can do from a genetic standpoint that help us understand, what exactly, what kind of inheritable disorder might we be dealing with. So the motor symptoms are just the tip of the iceberg, right? You think about all the things neuropsychiatric and cognitive, look at that. Depression, anxiety, psychosis, cognitive impairment. These are a lot of things that we have to think about and how we can help. And so we don't want to miss all of those different aspects of care. So in our assessment, when we see a patient, we are constantly screening for what are called the non-motor symptoms of Parkinson's disease. So there is actually a non-motor symptom standardized questionnaire that the Movement Disorder Society has studied and published about. It's very helpful in understanding if you see cardiovascular issues like lightheadedness, falling, drops in blood pressure, sleep or fatigue, right? Sleep disorder is part of Parkinson's, right? Fatigue during the day, it's nonspecific. Mood, cognitive changes, perceptual problems, hallucinations. Look at the way we screen for all the non-motor symptoms. Look over here on the right, attention and memory, gastrointestinal dysfunction, urinary changes, sexual dysfunction, and then of course other things like that are classified as miscellaneous. Pain, difficulty with taste or smell, change in weight, excessive sweating. So here you can see when we think about cognition and mood, right? Look at the things that we do for cognitive testing. We do Montreal cognitive assessments, mini mental state examinations. There are different other types of cognitive tests that we can do. There's something called a, that's not on here, it's called a mini cog. So if someone doesn't have a lot of time and you want to evaluate someone's cognition, you might actually ask them just to draw a clock and remember 3 words. And just that has been shown and has been published about being highly sensitive in determining as a kind of a quick screening tool about whether or not someone might have cognitive impairment. Depression, we might use Beck's depression inventory. There's a Hamilton depression rating scale. In our clinic, we tend to do what's called the Geriatric depression scale. The reason we do that is because we want to make sure that if we are experiencing cognitive impairment and we've done all of our screening that we needed to do, that we're not in fact experiencing what looks like cognitive impairment, but what is reality called pseudodementia, depression-related cognitive disorder. It was first documented in soldiers that were returning from World War II. And clinically, patients might experience features of depression or very subtle features of depression that might be hard to pick up. And so in many ways, this pseudodementia can look very much like dementia or cognitive impairment. So let's not forget the psychiatric aspect to Parkinson's. Depression and anxiety happen, unfortunately, in Parkinson's disease. It's a condition that affects not just affects our brain, and our brain controls our cognition, controls our psychiatric state, our behavior, our mood. All of that is our brain, right? And so a brain disease is very much a multifaceted clinical manifestation disorder. So This is what we tend to do in cases where we want a deeper dive in understanding our patient's neuropsychiatric or cognitive state in general. You're going to do neuropsychological testing. Neuropsychological testing is very, very important. It's about a 4 to 5 hour battery of tests, but it really does help us understand what aspects of cognition can be impaired. Is it attention, memory, planning, organization, motivation? Is it mood? A lot of that can be teased out with a neuropsychological evaluation. Now, our Montreal cognitive assessments are something that we do in our clinic. Montreal, despite being one of my favorite cities in North America, Montreal also did come up with this cognitive assessment tool. And in many ways, it does come from McGill. And so it's a way of really looking at, if you see the different aspects of cognition clearly stated in a Montreal cognitive assessment, it's based on off of 30 points. If you score a score of 26 or more, that is deemed unaffected. But I have to tell you, educational level and our ability to process things fluidly throughout the day as it can fluctuate, you might see different. It's not always, you can't just think about one number in trying to determine that. Now here you see, why do we do cognitive screening, right? And the reason is about 17% to 19% of patients may actually have some sort of cognitive dysfunction at first visit when they're getting diagnosed with Parkinson's disease, right? So cognitive impairment should go hand in hand in many ways in understanding the cognition with Parkinson. Here you see, if you follow this curve over time, if you see here, as time passes, and we might see a little bit of a gender difference, right? Women more than men might experience, if you have a diagnosis of Parkinson's disease, a higher risk, higher prevalence of dementia as the disease progresses over time. So unfortunately, the lifelong risk, the lifelong prevalence of cross-sectional prevalence is anywhere between 30 to 80% of developing dementia after a diagnosis of Parkinson's disease. So cognition, memory, attention, executive function, we always screen for that. We have to understand the cognitive changes that happen in Parkinson's disease. Here you can see it's not always memory. If you ask a patient with Parkinson's disease or cognitive impairment, do you have any memory loss? A lot of the times they might say, no, I can remember my past. I can tell you the story. I tell you when I got married, I'll tell you from start to finish what happened when I first had my child, when, these important life events, you can hear our patients, they might tell you exactly what happened. And sometimes I say, my goodness, I don't remember my life events that well, from start to finish. And I say, but then you do a Montreal cognitive assessment, you might see it's actually not memory. It's not that remote memory. It's a lot of it is difficulty with retrieval of current thoughts. It's not all of this memory loss from previous events. It's what's happening right now. It's an executive dysfunction a lot of the times that we might see. Difficulty with problem solving, changing our mindset. If you're thinking one thing and then trying to multitask or go to another thing, that sort of shifting sets is difficult. And then there's attentional impairment. Attentional impairment means where we have inattention, right? A lot of our patients might be properly diagnosed, but not fully correctly diagnosed with almost like an adult onset attentional deficit disorder, like an ADD. In reality, it's probably some underlying neurocognitive impairment that might be brewing as a result of the Parkinson's disease. So cognitive dysfunction, we always make sure that if we're looking for dementia, that it's not another cause of an acute confusional state, right? So it's not necessarily an infection that's causing a patient to be delirious or cognitively confused. We look for reversible causes of cognitive impairment. That's why we do a lot of those blood tests. The memory domains you see here, if you really think about it, it's not all the hippocampus that's affected for cognitive impairment. A lot of it is frontal lobe function that's affected. And that frontal lobe function makes it hard. the storing of memories is not hard in Parkinson's disease. It's the retrieval or access of those memories and that short-term retrieval of thoughts. Have you ever been to pre-corona, but have you ever been to a restaurant and you have a waiter who can remember everything that you said, and maybe you came with friends and you're trying to enjoy your evening. You have 20 people there. Well, maybe I'm having daydreams about restaurants apparently right now because I haven't been to one in so long. But if you Alyssa's like, yeah, exactly. So if you think about it, if those waiters have a very strong working memory. They're able to store for short term and then retrieve their thoughts. And so that's a working memory. That can be hard. That's a frontal lobe function. It's not a storage capacity function of long-term memory. It's a short-term working memory function. So what we see in our patients is that impaired executive function. Where are my keys, right? I left something around. I'm slow to retrieve words. Word finding is difficult. That fluency of words, things like drawing a clock or a cube, or what we call trail making tests. It might take longer for a patient to sort through things. They might get it right, but that kind of shifting from a number to letter and letter to number might be tricky. So the burden of Parkinson's disease, oftentimes it's not only for the patient, it's also for the caregiver. And especially when we include Parkinson's disease dementia into that. Whenever you think about Parkinson's disease dementia, you have to always do cognitive screening tests and understand what might be levodopa responsive or what might be cognitive medication responsive. You always want to make sure also that we're not dealing with Lewy body disease, right? Lewy body disease is basically when you have a patient with Parkinson's disease with cognitive impairment and fluctuations of alertness and cognition, variability of cognitive processing, psychosis like hallucinations and delusions, REM behavioral sleep disorder. When you have all of those symptoms all in one that happen close to each other, that usually indicates more of a Lewy body disease diagnosis rather than a Parkinson's disease diagnosis or a Parkinson's disease dementia or PDP, Parkinson's disease psychosis diagnosis. So here, what I tell people is that if you really look and you're comparing Parkinson's disease dementia to Alzheimer's disease dementia, there is a stronger cholinergic deficit, which means the acetylcholine levels are much more affected or low in Parkinson's disease dementia than Alzheimer's disease dementia. So the silver lining there is that the Alzheimer's disease medicines that improve acetylcholine may work better in Parkinson's disease dementia. So a lot of the cognitive dysfunction can be treatable. Now, what about neuropsychiatric screening, right? Neuropsychiatric screening, this is our own at Georgetown. We created our own screening tool. It's 15 questions, and we ask about the different aspects of psychosis. And we might ask, these are 5 questions that we ask. These are about hallucinations, right? Do you ever look at an object and think that it might look like something else? That's called an illusion, where things change shape. Do you ever feel the presence of a person or a family member, or a spirit, or an animal that might not be there? That understanding of feeling of presence could also be a hallucination. You don't have to necessarily see them. What about seeing shapes, colors, shadows, hallucinations in the periphery? Those might be passing hallucinations. What about actually seeing hallucinations, right? You see an animal or a spirit or a person or a shape. That's an actual frank visual hallucination. And then do you ever hear? What about those auditory hallucinations or tactile, feeling things or smelling things? I have patients that have what are called delusions of parasitosis, where they might experience, they feel like bugs are crawling in their skin. And it actually happened to my grandmother when she was on too much medicine. So one of the medicines that she was using for her pain in her legs, she was on higher doses. I still remember she was picking her skin, thinking that there were bugs inside. And it wasn't until we kind of lowered one of her pain medicines for her legs that went away. But when I talked to her about it at the age of 94, I say, remember when you were 90 and you were feeling? She goes, no, that actually happened. She actually felt that it happened. And it's hard for her to kind of wrap her mind around the fact that those were actually delusions of parasitosis. Now, the other things that we ask are about delusions. So we might ask about if people have feelings, ideas, fixed ideas that of paranoia, or there's something called Capgras hallucinations, where they might feel that their family member is an imposter. And then there's a financial delusions. So a patient of mine actually was leaving their house and wandering, and would leave at 3 in the morning. And it wasn't until I finally dug deeper and I said to him, are you leaving the house for any reason? He said, yeah, I'm going back to my old law practice because I had money there, and I'm worried that my law partners at my old law practice are taking my money. And my patient's wife looked at me and said, he's not going, he's been retired for 10 years and there's nobody at his law practice. And so some of these neurobehavioral changes are there. And then we screen for things like aggression, agitation, anxiety, lability, difficulty with nighttime, sleeping, nighttime behavior. And then, of course, our goal is to understand Parkinson's disease psychosis more as well. When you think about the different neurotransmitters that are involved in Parkinson's disease, you see here dopamine. We think a lot about dopamine. But what about acetylcholine? We talked about the cholinergic deficit, right? Acetylcholine levels in Parkinson's disease dementia might be a lot lower than in those that have Alzheimer's disease. So augmenting acetylcholine might be helpful. What about norepinephrine? We've talked about this before, but norepinephrine is a feel-good neurotransmitter that might give you energy. It's basically adrenaline. It might stabilize your blood pressure so it doesn't drop, right? Norepinephrine is an important neurotransmitter that's affected in Parkinson's disease. And then let's not forget serotonin. They're all in different centers of the brain. And what we know about Parkinson's disease psychosis is that when we want to approach it, now that we've screened for it, you really want to make sure that the Parkinson's disease medications for Parkinson's disease psychosis, that you're making sure you're not overdoing with levodopa. You're making sure that you are ruling out infection. You are screening for cognitive impairment and understanding, because Parkinson's disease psychosis actually can be related somewhat to progression of disease. And that's what this talks about. Even if you think a patient might be freezing more, you might be screening. If you're screening them for their freezing of gait, you might also want to be thinking about actually helping them with their hallucinations, because you might not screen them for hallucinations, because the odds are if they're freezing, there might be some cognitive dysfunction there as well. Actually, there was a study that was done using the Exelon or rivastigmine patch, and that's a medicine that's for cognition. And it actually showed back in 2016 that there was a reduction of falling if you can improve someone's cognitive function. So this is about hallucinations, right? This is actually Abhishek Lenka is a resident of ours. And I got to tell you, when I was putting together a presentation, I saw this paper. I had no idea who wrote it. I put it on my presentation, and then I started looking, because you always have to cite what you present. And I said, Abhishek Lenka, you're my resident. I called him. I said, I just cited your paper. And so this slide is very important. But the point here is, if you see that psychosis, just like in a previous slide, I showed you, I'm sorry, don't get dizzy, but I showed you here for the non-motor symptoms that we screen for. This is the non-motor symptom questionnaire, right? For the non-motor symptoms, the tip of the iceberg, just the motor symptoms are the tip of the iceberg for all of the other parts that can be affected, right? Constipation, orthostatic hypotension, hyperhidrosis, which means extra sweating, urinary dysfunction, pain, insomnia, fragmented sleep. Look at all those things. That's just the tip of the iceberg. If you look, don't get dizzy now. You can close your eyes. I'll tell you when to open them. If you look here, And you see the tip of the iceberg might be hallucinations, but if you dig deeper, you might see REM behavioral sleep disorder, cognitive impairment, depression. You might see more larger scale neurocognitive networks that are affected. And so we always need to think about things in a dynamic way when screening. And these are medications that have been approved for the use of, for treating Parkinson's disease psychosis. Right now, the drug approved for Parkinson's disease psychosis is pimavanserin. And this is based on an update by the movement disorders in the movement disorders guidelines journal. And if you see here, what about deep brain stimulation, and where does that fit in terms of our screening and assessment? We are doing a lot of what I just mentioned, right? If you look, we are making sure that our patients, first of all, are clinical candidates, right? So before going for deep brain stimulation, you actually need to make sure that their neuropsychological testing is okay, right? So our patients might need deep brain stimulation, but if they're cognitively impaired, they are no longer candidates for deep brain stimulation. So there is a window there. There's a window there where we want to kind of promote deep brain stimulation earlier on in the condition, because there's a window of opportunity that we have to describe. We do that on-off testing. On-off testing means we give our patients carbidopa, levodopa, and see if they go from a Parkinson state to an improved state, make sure that they are responsive to levodopa. We get MRI, we do neuropsychological testing, like we said, psychiatric evaluation, because if there's too much depression, also they might not be candidates for DBS. And so what else do? We optimize therapies. We think about all the different options of optimization of therapies. We find out about deep brain stimulation if they're good candidates, if they have good social support at home. Do they have good social support? Do they have a team that can help them evaluate and adjust the deep brain stimulator when necessary? These are the different locations where you can decide to place the DBS, and where we choose to place the deep brain stimulator in the brain is very much dependent on the UPDRS motor score and the type of clinical syndromes that our patients have. So if they have more dyskinesias and they're not on very high doses of carbidopa, levodopa, or if they have gait impairment, a lot of the times the globus pallidus might be a better place, especially in patients that also might have dystonia predominant Parkinson's. So all of these screening tools, all of these assessments and evaluations for our patients that we do clinically that we mentioned today are very important also surgically. And now this is our last slide, but I wanted to go through it so that I keep your attention before keeping you on for too long, and we can do Q&A. But here you can see telemedicine has really been wonderful. It's really changed the way we can access our patients. I'm sure in the social work world as well, it's been very, very helpful. I've told you already, hired a wonderful social worker. She's doing a lot of her therapy. She's a licensed therapist. She's doing a lot of her therapy remotely. And it's saving our patients a lot of time, travel. That immobility in our patient population does exist, and it's hard for them to get places. And so there's a lot of pluses to telemedicine. And there are even now DBS companies. One of the DBS companies now is allowing they've created a software that's FDA approved for remote care. So a patient can be at home. Like if I have a patient in Virginia Beach, which is about a 4.5-hour drive from Washington, D.C., they used to have to come to us, but now I might be able just with their own iPhone, I'll be able to adjust their DBS from miles away. And so that's going to be something that's very, very helpful. The other thing that telemedicine has helped us do is optimize efficiency with research visits. So a lot of we were kind of living in the Stone Ages before. Clinical research has become a lot easier. We have a lot more participation actually in clinical research trials, because they say, oh, I don't have to trek all my way to Georgetown 7 times in a month. Sure, you only need to see me twice a month, not 7, and I don't have to park and get stuck in the parking lot and then walk through a maze that is Georgetown to make it to a clinical research area in the setting of a pandemic, right? So all of these things make it really helpful. And one of the reasons why I was almost running behind today was because I was on a call, a virtual call with one doctor at Inova Fairfax, another doctor at Georgetown, and I'm in my McLean site meeting, and we were all talking about a patient. It's actually, I think, helped us doctors even communicate, which has been one of the hardest things I know for our patients and for us to actually get to. So I hope this was helpful. It was a quick, rapid review, but I wonder if there are any questions. I know that I was seeing a bunch of the chat box light up. So
Yes.
I'm assuming there are.
There are several questions in here. Yes, it's been it's been a little bit busy. So a couple comments and questions from, excuse me, a couple social workers that are on, and they were really talking about that they find it difficult to find a psychiatrist who understands Parkinson's and the challenges that come along with it. And then another social worker said, yes, it's been really difficult to find that. And so wondering if you have any recommendations about that, or I don't know,
challenging
database.
Yes, that is one of the most challenging pieces to the puzzle. Eventually, I'd like us to hire a geriatric psychiatrist that has geriatric psychiatry training. We have a great psychiatry team, but we're in a niche in Parkinson's disease. It's a niche that's you have to understand it in and out. In many ways, I wish that I did almost like a psychiatry fellowship in addition to what I've done so far, because it's so common for me to have to wear that psychiatry hat and rely on psychiatry to help us. And a lot of the times it's beyond my scope. I can help in many ways. I use antidepressant medicines. I use things like SSRIs and SNRIs. But when we start seeing kind of refractory depression, when I need higher levels of understanding, that referral basis becomes even harder to find. There's a geriatric psychiatrist here. I think they're booked months in order to see them, in order to see our geriatric psychiatrist in the DC area. And so it's really tricky. You got it. I think we need more geriatric psychiatry trained psychiatrists. That would be helpful. But then the cognitive behavioral therapy piece, that's where it's helpful to have even social workers that can perform therapy, behavioral therapy. It's very, very helpful, especially to find someone that's understands the field of Parkinson's disease. I think that's an invaluable, if we could have more of those within the Parkinson's world, we'd be in better shape.
We would be. That's something, we could add that to our to-do list. Like, we'll figure out how to create a little database of and maybe we can kind of get a group together to kind of brainstorm. How do we pull together the people who do know about this? Because we know they're far and few between, but boy,
yes, you got it. There are thought leaders in the country.
Yeah.
But you're right. They're few and far between. There's definitely a drought of psychiatrists that can really handle neurodegenerative conditions like Parkinson's disease and the like.
Right. Let's see, there was another one about, hang on a minute, let me just get in. We've been using telemedicine to screen patients. Some in my clinic feel uncomfortable, however, making changes to medication and other similar things online. How do you think this, however, I think it works well. Sorry, I'm not reading well today. Do you have any suggestions on how I might approach this with my clinic? So providers in the clinic who are uncomfortable making adjustments in medication and really doing anything with telemedicine.
Yeah, it's a great question. And it always falls on comfort level, right? You got it. And you have to, in order to, it's almost like Karate. So, okay, how am I getting to Karate Kid? Okay, it's like Karate Kid. So if you remember, well, I kind of make the joke because I'm Dr. Torres Yagi and Miyagi. People remember.
That's right. Yes, of course.
Some days they just
Dr.
call him
Miyagi.
Dr. Miyagi sometimes. But Daniel's son, if you remember the 1980s version of Karate Kid,
Yep.
he blindfolded him, I think, at some point, and he had him do things, repetitively blindfolded. And so it's very much about comfort level. If I feel that I can hear a history or see a person just visually without actually having them in my office and doing the usual steps that we're lacking, what's missing from a clinical evaluation online is you can't check reflexes, you can't check for rigidity, you don't really have a strong understanding of just on a video, how they're really walking, right? You also can't really check their strength. You can't check their sensation. These are multiple aspects of our full neurologic exam that are missing. So you really need someone who feels comfortable listening to a history and evaluating a case visually or over the phone, as if that was part of your training in residency and fellowship, and now we were thrown into it because of the pandemic, and you have to make decisions, therapeutic decisions over a year. That comfort level does continue to increase, but it's a conundrum. You're right. There are practitioners that have not wanted to do it because they felt that the decisions that they might make weren't the best decisions done virtually. And so, right, it's hard. So I also just wrote a paper with my team about telemedicine.
Oh.
And but we haven't published it yet. But essentially, we looked at 4 movement disorder centers in the United States, and that were thrown into telemedicine. It was the first 6 months of the pandemic, and we surveyed the multiple clinicians that were in these movement disorder centers, and we evaluated what they thought was an effective virtual visit. And one of the questions was about this point. And I think the point is making medication changes. Mm-hmm. So you got it. There are plenty of barriers to actual therapeutic interventions due to telemedicine. And the other barrier was the pandemic environment. So patients said, if you're going to start me on a new medicine that might cause these side effects, and I'm scared to leave my house and go to an urgent care center, and your office isn't really fully open for in-person care, then no, you're right. The patient might feel uncomfortable and the doctor might feel uncomfortable. But in a better environment moving forward, if we have that kind of comfort, the patient has that comfort that at least the COVID environment has improved and they're safe enough, and maybe they've been vaccinated. And if something were to go wrong, they can still go to an urgent care setting, or they can come to your office as needed for a problem. In that sort of environment, actually, it might help kind of improve that comfort level of those clinicians. Say, hey, look, if you're going to start someone on a medication that for on-demand treatment of Parkinson's disease, and it's a new kind of family of drug for this patient, for example, but there are all these risks that might happen. If something were bad to happen, you could come in and we'll see you. Then maybe if that sort of ecosystem is available, it might be better. So right. Kind of that would be my suggestion on how to approach that. Say, in an improved environment, improved access to care is important. Mm-hmm. Reminding people that even check-in visits, a hybrid approach, I think, is where we're going to be. That's where I'd like to be. We have in-person visits for those that need DBS adjustments, for those that need Botox or any other toxin injections, or important visits, maybe yearly or every 6 months, in-person visits. But for those check-in appointments where we're just checking about whether or not a medication's working, you could do that virtually.
Mm-hmm. I love that hybrid piece, because it would be really sad to lose the telemedicine gains that we've made during, that's the one thing that can come out of this potentially. So
yes.
Absolutely. Okay. Someone asked if you can pull up, let me find which one. If you can pull up one of your slides, can we see the 2 iceberg graphics again and get the link to the article referenced?
Yes, sure. I don't know. I have the reference probably written below. Hold on one second.
Sure.
Oops. Okay, hold on here. Don't get dizzy. Okay, so this is the first one. So this is Abhishek Lenka. I know him. I told him, I said, you're famous because you're our resident. He's very well published. This was a paper that he wrote. I guess he's the first author about hallucinations. And so that's the reference there.
Fantastic. Minor hallucinations in Parkinson's disease, a subtle symptom with major clinical implications. Isn't that the truth?
That's right. That's
Yeah.
right. And let's go back to the other one. Here we have it. Sorry, I'm moving quickly.
Right.
Okay, perfect. And so this was in Annals of Neurology from 2006. And so what this is kind of telling us is that, right, so this is an iceberg. And what it's telling you is that the tip of the iceberg really is just the motor symptoms, but it's multiple. So the substantia nigra is the part of the brain that's affected in Parkinson's. But what this is showing you is that below the surface, under the water, beyond that tip of the iceberg is actually, look, all the other aspects of the nervous system that are affected, right? The pons, the hypothalamus, the spinal cord, the autonomic nervous system. We saw the heart, intestinal tract, the bladder can be affected in Parkinson's. The olfactory cortex, that's your breathing center, right? Your temporal cortex. It's not all about the movement centers of the brain. And all of these aspects of the nervous system that are affected translate into the different non-motor symptoms that we see, the neuropsychiatric and cognitive, the sleep disturbances, the autonomic dysfunction, the sensory disturbances like pain. And so you got it. Movement, we should change the name maybe. Maybe it shouldn't be only movement disorders because it's not just a movement issue. It's everything else.
This slide is amazing. I mean, we could do an entire live stream, I think, on just this slide because it is so misunderstood outside of movement disorder specialists, how the entire person is impacted.
Oh, definitely. You got it. It's exactly like the entire person kind of the motto at Georgetown. It fits very well with Parkinson's disease care because you got it. I mean, how many times, we can get the motor symptoms sometimes under control, but sometimes the hardest thing to control is anxiety, right? And so, or depression. It's not uncommon for that to be one of the trickiest pieces in taking care of, or the cognitive impairment, or the psychosis. And so these are the things sometimes, for example, when we try and treat the depression with medicines, REM behavioral sleep disorder can get worse with the medicines that we use for depression and anxiety. And so it's always this balance. And so when multiple parts of the nervous system are affected in Parkinson's disease, that's when it gets even harder to treat because you have to start employing all the different agents. An example of that is if you're trying to treat a patient's movement disorder with medicines like levodopa, any formulation, and they have orthostatic hypotension, and the levodopa makes the orthostatic hypotension worse, right? We know that orthostatic hypotension happens because of the autonomic nervous system that controls blood vessel dilation and constriction is affected. But so in order to treat the movements, we might actually have to stabilize the blood pressure with another medication. And so that's kind of the combination. Those are the kinds of complicated conversations that we're having.
And that trade-off of, like you said, the medications, the benefits, and where it helps one and might make the other more complicated. Kind of tied to this, and you were talking about the hallucinations and different things that you can't see, like the motor symptoms. Somebody sent a message to me asking if the questionnaire, I think you showed us a Georgetown questionnaire that you developed. Is there a questionnaire available that people can use? And I don't know.
Yeah, is it for psychosis or for non-motor?
They didn't put that specifically. So I don't know.
So this is the non-motor questionnaire that's available through the Movement Disorder Society. It's a standardized questionnaire that's been around for a long time. And oops, sorry. And so this is kind of something, we don't always do this in our visits, but this is, I wanted to present the standardized tools that are recommended. And so this is something that we tend to do. We kind of are trained to ask about these questions, not always so formally. But the other aspect, the ones that we created ourselves, was a neuropsych screening tool at Georgetown, where we screen for hallucinations, delusions, and then we ask if there's been behavioral changes due to the hallucinations or delusions, and that helps us kind of understand, should we take a therapeutic step? What's the next therapeutic step? But there also, you can look, so the SAPS PD is a scale that looks at psychosis and Parkinson's disease. And so that's a standardized measurement that we use also in clinical research to kind of understand and gauge severity of psychosis. The Neuropsychiatric Inventory is called the NPI, and that is also a standardized tool. That it's a very long, a standardized tool to screen for psychosis and delusions and other neuropsychiatric changes that can happen. But they also have a neuropsychiatric NPI-Q, which is a quick version of the NPI. So that's another way of evaluating someone's neuropsychiatric state.
Excellent. Okay. Yep. Because somebody said they wrote me, and they wrote actually everybody, and said psychosis. So yep. And I put in there the more to Parkinson's too, which is also an available site. And then the tools you just mentioned, I was just Googling while you were talking. The NPI-Q looks like it's pretty readily available.
Yes.
Yep. So those are good. Good. Okay, let me see. I know there was one more in here that I needed to get back to. Oh, this is tied to telemedicine, also needing CMS to continue to cover it. Do you know of any activities that are being done? Is there any work being done on that as providers, people can actually participate in and share their perspectives to keep telemedicine available?
Yeah, so you got it. It's kind of I think we're just going to have to see where it goes. Right now, we're still under emergency use of telemedicine services, but there are some insurers that are starting to peel back coverage, and so you got it. I don't know for now. I haven't heard of any plans, but I think as a community of healthcare members, people that are there trying to improve access, to talk to patients, I think it's important. Telepsychiatry has been around already. They were able to allow for actual telepsychiatry appointments to be done virtually and continue to get compensated through CMS coverage. And so I don't see why now, once we are thrown into the telemedicine age, that we can't continue it. There are different healthcare organizations that have been doing it for a long time. The Kaiser system, from what I know of, has been doing telemedicine for a very long time. But again, they're kind of their own insurance company and healthcare provider all in one. And so we kind of have to, I think we have to do what's right for our patients. And I agree with what Sarah said, that the hybrid model, I hope, never goes away. Actually, the first question that I answered, or one of the first questions, was about some healthcare practitioners that are concerned with telemedicine and starting a new medicine. I've actually I've leveraged the use of telemedicine, especially after starting a new medication. Now I can do quick check-ins. Now I can see patients a lot more because we've kind of removed a lot of the red tape. Now I can see a lot more patients that need to be seen closely. So close monitoring has become easier. Now, is it in-person monitoring? No, I mean, a lot of it's remote, but these are patients that might have had to travel 2 hours to get to our clinical site. And I'm checking in with them, making sure that I'm on the right dose of a carbidopa-levodopa formulation like Rytary, right? So And I say, oh, how's it going? Did this combination of medicines work for you? And they might say, no, actually, I'm walking more slowly. I'll maybe watch them walk, right? With someone watching them, making sure that they're safe. And I say, oh, you know what? Yeah, last time I saw you, you were walking a little bit better. Let's increase the dose a little bit. So these sorts of things, rather than have to wait 3 to 6 months to see your doctor for a follow-up, or 6 to 12 months, now I can see you sometimes weekly. It just depends on the case.
Yeah, I'm glad you brought that up. I remember another doctor sharing that with me, that actually they were finding that it was easier to manage their patients because they weren't they weren't in trouble by the time they came in to see the doctor. They could connect better.
Yes. And then if you're trying new therapies, that communication piece is key. And then the access is key. Because you might say, oh, what used to happen also, we would prescribe a medicine, we'd lose touch because it's been so long. And then they'd say, oh, the insurance wouldn't cover the medicine that you prescribed, so I never started it. Or I took a medicine and it made me feel like I was tired, and so I never continued it. And so now you can kind of monitor them and help them. And that provides comfort to patients, knowing that they can see you more regularly. They might be more willing to do something that might benefit them.
Absolutely. And one other last, I think we're done with the questions, but one other thought I had too, as you were talking about comfort, which I think, is so important, because it does take a while to get used to, being on a flat screen, and you have to, get past the fact that you can see yourself and, things that you don't have to deal with when you're sitting in a regular meeting with somebody. But once you get past that, if you can, one of the thoughts I had, I think John asked this question, is to maybe make some times with different providers that you work with using this tool just for a meeting. Because I think as people get more and more used to it, it becomes more and more second nature. Don't you think? I've not met you yet, and I haven't met half of our team yet in person. But I know when we get together, it'll be like, oh, I've known you for years,
Right. I think that's right. The first trick to that one, Sarah, is turning off your own video, because otherwise I would just watch myself talk the whole time. I move like this, and then it's very hard not to watch yourself talking. That's number one. That's my trick. And then you got it. I think staying connected from that end is really important. And you're right. I think you have to see the positives of telemedicine. In order to kind of adopt it fully. You could look at it negatively, and you could rip it apart, right? But you could also look at it positively and think about all the positives that it brings.
Absolutely. Absolutely. Oh, thank you so much. And I think Lindsay might have left, but if you're on and you need a certificate of attendance, we're happy to send that to you to pass that along. Especially, I know that some of the social workers have been able to use this to submit, and I think some PTs have used it in some of the other talks that you've done. So awesome. This has been fantastic. And I agree, Judy. I love that positive attitude. Dr. Torres-Yagi is always good for that. He always can put you in a good mood.
Thank you. That's nice to hear.
And you can always learn something, always. So I'm so glad that we were able to be with you today. Thank you again for taking your time and walking us through that. There's so many great tools out there to be used.
That's right.
Yeah, so I think it just takes some of the worry out. This will be available. We will send this out, let people know when it's available. Again, thank you, Judy and Acadia. Thank you, Dr. Torres-Yagi. And it was wonderful to be on here with all of you today.
Thank you so much. Have a wonderful day.
You too. Bye-bye.